Hi, Joel. Thanks for meeting with me. So
Entirely
most
my
of
pleasure.
our students will know you from Snug 202, and you're going to be with second year students again in Snug 206 this semester.
I pretty definitely will be, yeah.
Thanks. We just thought it'd be good to chat to you about people who have experienced chronic health conditions and their mental health and how
Mhm.
these sort of things affect mental health for people who are, not necessarily out and about in the community, maybe
Mm, mm, mm,
socially
mm, 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 mm.
isolated and have a lot of, um, I suppose, the attention they have to pay to their health is greater than most of us. So
Mm,
I'm
for
just
sure.
wondering what you think of that and what's your experience been with people who've got chronic health conditions.
Look, I guess it'd be first, I think, really worth mentioning that it's very well established that um you cannot quarantine your mental health from your physical health or from all kinds of other psychosocial factors. And generally, people who suffer mental health issues often do so as a consequence of a whole bunch of different compounders all happening at the same time. And physical illness or chronic conditions are no different in this regard. So there's a formal model known as the stress vulnerability model,
Yeah.
which is all about the way that there are certain innate factors which predispose people to different mental health issues and difficulties, but it's also external factors that have huge implications for one's mental health, and certainly chronic conditions are a part of that. Um, I mean, if you really want to look at, say, I mean, I'm sorry to be morose, there's no avoiding it here, but you can look for yourself on the ABS website, and every year they publish a report about causes of death, and a very substantial proportion of the report is focused on suicide.
Yeah.
And you can absolutely see that chronic illness is very definitely associated with rates in suicide. Not just chronic physical illness, but chronic mental
Yes.
illness as well. And so chronic illnesses like absolutely have a big impact on people's mental well-being.
Very sadly, yeah. And of
Yeah,
course, encompass people with, like you say, chronic mental ill health as well as chronic physical ill health. So,
yeah,
as
of
you say,
course.
it's everyone can be affected. Yeah.
Yeah, of course. And it just, yeah, I mean, um, things like a chronic physical health, again, a chronic physical health problem, it's gonna cause far more problems than you probably might realize as someone who doesn't have a chronic health problem. Like the issues with employment that will come with that, the issues
Yeah.
with mobility that will come with that, the
Yeah.
issues with physical pain that come with that.
Absolutely.
Yeah, yeah,
And that social isolation, which has been studied a lot more these days, the loneliness factor for people with chronic ill health.
yeah,
So, just that
absolutely.
alone, of course, must predispose people to depression, I imagine, let alone
Yeah,
the
well,
pain, chronic pain, and yeah,
yeah,
inability
well,
to live how you used to live. So,
indeed. And it's there's also I'm adamant that I've read evidence about the way that loneliness is absolutely associated with exacerbations in physical health, higher blood pressure, um, and I believe there's evidence of in people who suffer from extensive loneliness, there's evidence of sustained sympathetic nervous
ah,
system activation. And
yeah,
so that's like
the
obviously
stress
sympathetic.
response.
Yeah,
Yeah,
indeed. So the sympathetic nervous system, it's okay in the short term. That's what it's supposed to be for. But extensive hyperactivation of the sympathetic nervous system response is totally harmful. And you see that there's evidence of this in people who've suffered from extensive loneliness and social isolation. So it's not, it's not trivial. It's not just
no,
sad. It's physically harmful for their bodies,
yeah, yes, it's physiologically a thing that happens as well, isn't it?
Yeah, absolutely. You know.
So, for students who are perhaps talking to people with some form of chronic health condition, how could they approach their mental health, perhaps?
I guess everything needs to sort of be you know, it's highly contextual, and you need to look at these things on a case-by-case basis. I think one of the mistakes that a junior person might make, like a student, not that there's anything wrong with being junior, but I feel like people will often gravitate towards cliches as a way of navigating conversations and interactions, which is, it's not necessarily harmful, but it really doesn't do any good. And cliches are usually opted for when people feel a little bit uncomfortable, and it shows. And so it sort of creates a bit of like a barrier between you and the person that you're caring for, you know? And so,
Yes.
and I know it's hard because the temptation to sort of fall back into cliches really, like in conversation, really is there, but it's best avoided. I guess one of the things also to keep in mind when you're thinking about people's mental health, and you're concerned about their mental well-being, and again, this is a little bit morose, sorry, but it's well known that sometimes people with chronic health conditions might exploit something related to their chronic condition in order to affect their suicide. And so that is something that you need to be mindful of. And I know that's a bit of a step left, but
Yes.
so for example, a colleague of mine, a renal nurse, she told me a story, an anecdote about a young man who was undergoing dialysis. And that's absolutely a chronic health problem.
Oh, yes.
And, you know, and it takes over people's lives, dialysis.
Oh,
It's just,
yes.
it's so incredibly rigorous and taxing on a person to undergo that
Yeah.
procedure. And this young man, he died by suicide, and he did so by consuming a really large amount of dried apricots. And I know that sounds a
Wow.
bit odd, but yeah, but the
High
reason,
potassium and
exactly right. Yeah, he knew full well what he was actually doing, and um and that's sort of an example of the way that sometimes, if you are caring for people with, say, chronic health conditions, it's not out of the question that something related to their condition will be, in a sense, exploited to affect their own suicide. And so you have to be quite mindful of that sort of thing.
yes.
And there's another example for people who are, say, who have a spinal injury, for example. Um, if they have an indwelling catheter,
Yes.
if they should clamp their catheter and
Yeah.
engorge their bladder, there's a well-known phenomenon where their blood pressure
Yes.
spikes to an extraordinary
Awful.
extent, which causes, yeah,
Shock state. Yeah.
yeah, and it causes a really big stroke. And many people have died by suicide via this means. And so if you are caring for people with chronic conditions, it's worth sort of keeping somewhere in the back of your mind that there's a possibility that something related to their condition could be, I guess, utilized to affect their own suicide. And I'm sorry that's a bit morose, but
Oh, no,
it's a real phenomenon that, like, you might actually really want to think about.
and
And in both those examples, sorry to talk over you, but there are, when you're caring for people with chronic conditions and you're concerned about mental health, you'd also want to think about the demographics of this particular individual. So, for example, if you're caring for a man with a chronic health condition, right away, you know that this person is far more predisposed to suicidal behavior than, say, a woman with the same condition, because men represent 75% of all people who die by suicide. So just being a male really is a big compounder for that sort of risk.
That's a horrible thing you can't change either, isn't it?
No,
In
no,
terms of
not
risk
really.
factors.
No,
It's
no.
awful.
Yeah, and so yeah, there's a lot of things to sort of think about and take into account, you know, when you're caring for people with these chronic health conditions, you know. Yeah.
And I think going back to your talking about cliched health, the way we approach people, I think sometimes our tick box assessment forms and other activities that are just, right, I'm going to ask you a series of questions. Tell me what you think, when we don't even know the person, does
Yeah.
not help us engage in an authentic way that helps them to tell us how they're really feeling.
Yeah, it's really funny you say that, because because you're really right. It's well, I can't just say New South Wales Health, but healthcare systems in general have an endless number of forms that you're supposed to fill out, and they don't really they're not really conducive to authentically therapeutic interactions, not really at all. They're
No.
there seemingly more for the sake of diminishing organizational liability for anything that
Mm,
goes wrong. And so you can't really rely on those forms for the kind of assessment that would really properly um, assess someone's mental well-being. You know,
yeah.
the only way that you can really do that, I think, is through a real, authentic, knowing relationship, which you
Yes.
can't get through a checklist, you know,
No.
and that might mean that you really do have to engage with other family members if that's a possibility as
Yeah.
well, and people. And I mean, you know, you might not have an authentic relationship with the person that you're caring for. You know, like you might have just met them in an ED, but it could be that their loved ones will be a really powerful and important advocate for this person that you're caring for, you know, and so listening to them can be you know, the next best thing.
Great. Thank you. And yes, that whole listening is can be challenging if they've come into an acute care setting and we've got limited time, but actually the most important question is after you've done your tick boxes is perhaps, well, how are you really? Once you've got to know them a little bit. So
Yeah.
perhaps it's easier out in the community to get round to that sort of conversational style of, yeah, I'm really interested in actually how you really are.
Well, you know, it's funny, like there was a in a mental health unit that I worked in, there was a sort of well-known phenomenon that the cleaners
Ah,
the cleaners knew people that
yeah,
were in the hospital better than the clinicians, because the cleaners would, you know, sit with them at the bus stop and they'd share cigarettes. And
right. Yes.
those circumstances are conducive to an authentic I guess, set of interactions, you know,
Yeah.
where you have relatively equal power, um,
Yeah.
you know, and no sense of threat is looming from the cleaning staff. And
Yeah.
so these were the people with whom they shared anything that would resemble a therapeutic relationship. And so
Oh,
there are pretty definitely problems the organization of with the organization of healthcare, especially in mental health care, I think, yeah.
yeah. Well, and just in wards in general, people are rushing around with a computer on wheels. They're not really thinking about positioning themselves to be at equal level and to be more conversational, I suspect, and what my research has said. So
Yeah, well,
we have
I
to
think
be really aware of those sort of barriers to
yeah,
engage
well, I think
people.
you're right. Like I reckon one of the really big problems is just workload, especially in the medical setting.
Yeah.
Medical setting is so heavy and there's so much going on, and you just almost don't have the option of developing the kinds of relationships that really would be therapeutic in nature. It's just not an option when you've
Mm.
got, you know, an incredibly heavy when you're on an incredibly heavy surgical ward with people who really are ill and sick, and you know, someone called in sick, and you're struggling to get, you know, everyone their medications that they need. And
Yeah.
it's like,
It's
this
all
isn't like,
task focus, really.
oh, 100%, you know,
Yeah.
and health organizations don't really focus on things that that aren't task orientated, because you can't really you can't in a objective way sort of prove that you engage in a therapeutic relationship to a certain end, whereas with
Mm.
medications you can do that. You can record medications very clearly, you
Yeah.
can record fluids very clearly, you can record circulation obs very clearly, but for those non-tangible elements of care,
Mm.
those are the first things that get sacrificed when things get busy, um,
But
because you're just
they're
not
the
accountable.
ones that people that we care for really want to see and have with us, those sort of
Yeah, pretty definitely.
relationships, the conversations, the care, the
Yeah.
kindness, the compassion that
Yeah.
is immeasurable, really.
And I mean, this might seem like a bit of a funny, this might seem like a bit of a left field thing to say, but I've certainly cared for lots of people with chronic conditions. And I think it's good to have a bit of a sense of humor in your interactions with them, and
Yep.
be funny. And, because I think quite often when they receive visitors and family members, it's a bit sad and sullen. And
Yes.
because, and I understand, like, it's hard to see someone you love like sick and unwell. But going in there and sort of having a bit of a pub conversation with them can
Mm.
really like be such a warm thing to do and so nice.
Instead of focusing on their ill health, just
Yeah,
make
yeah.
it more, yeah, you're a person that I'm talking to. Yeah.
Yeah, completely.
Yeah.
And it puts them at ease completely. Like,
Yeah.
I don't know, there's a funny story. So I was caring for this lady, and she was a relatively young person, but I think she'd been on, she had a lot of chronic conditions, particularly related to her respiratory
Yep.
system. So she was on long-term prednisone, and she was so sensitive to touch. Like the slightest jolt would really, really make her incredibly uncomfortable. And
Yes.
so it was, yeah, she was in a lot of pain kind of all the time. I don't remember exactly what was wrong with her because it was a long time ago now, but I remember like that she was very sensitive to touch and getting bumped and stuff like that. So we had to be very, very careful. And she had these TED stockings on, and she's like, Joel, like these TED stockings are absolutely unbearable. Like you need to get them off me. And of course, after I explain, like they're there because we don't want you to have a clot or anything like that. She's like, I understand that, but I really need you to get these things off me. And okay. And so very tenderly, I sort of tried to start, peeling them off. And you know what TED stockings are like. They are
Yes.
they're like a skin on the person, And it's like, it was too painful for her. And it's like, okay, this isn't working, obviously, like, because I can't get them off by pulling them off. So I just pulled out a little pair of scissors and started, that's the only way to get rid of them, safely.
Yeah,
And
quickly and easily.
yeah. And I was slowly cutting away carefully. And she just laid back and she's like, oh, like the relief from having the TED stocking removed was palpable for her. And
Yeah.
she humorously said, oh, Joel, I've got to tell you, getting that TED stocking off is better than sex. And I said, better than are you sure you're doing it right? And so that was, but like she really laughed at that, and it was
Yeah.
funny. And it was a real interaction where,
Yes.
we kind of had gotten to know each other over, the course of time. And talking to her like she's an actual real person and not a
Yes.
stereotype of a patient, it really makes, I think, a big difference to their stay and the
Yes.
way that they experience, healthcare. So those
Absolutely.
authentic, real interactions where you really talk to them as though they're a real person,
Get
and
to
not
know
like
them.
and not an illness in front of you. It makes it makes such a big difference to the way that they experience everything,
Yeah. So
things like that.
language is really important when we're talking with and about people, I think. So changing the way we talk about the person in the bed with the chronic obstructive pulmonary disease rather than the COPD, bed 4 is
Bed 4,
really
yeah.
important. So,
Yeah, bed 4, bed 28 instead of,
yeah.
I can remember
John.
actually when we
John in
started,
bed 4.
yeah, John, I can remember when we went from doing handover in the nurse's station to doing
Yeah.
handover at the bedside.
Oh,
I can
yes.
remember the transition. And it was also, and also what we did is that we stopped using the term bed 4, bed 5. We'd go to the bedside and say, Mr. Zimiecki and Mrs. Jones, like it was a totally
Yes.
different thing.
Should be. And they should be involved in that handover. So the premise was you go to the bedside, introduce the person, and they tell you what's going on as well, not just you in a room
Yeah,
chatting
yeah.
about someone, you're with them, talking with them about them.
And
But,
you know what? I
um,
reckon it's also way more you're way more likely to remember something if it's not just an abstract piece of information. If you can see like how the medical handover, whatever information it is, like if you can see the person in front of you and how it relates to that person and what's going on, what IV antibiotics they have hanging, it's a totally different experience,
yeah,
because I think
absolutely.
nurses in particular in general kind of um enjoy um kind of they're not so I reckon generally nurses aren't hugely into just like memorizing abstract information. Seeing how it relates to a human being is what like really gets our
Mm,
brains sort of going. And so,
That's
yeah, like,
really good to see a live person in front of you
yeah, not just an
experiencing
abstract
whatever you're
idea.
talking about. In
Yeah.
theory, it's much more helpful. And a lot of
Mm,
students say that too. Even
mm,
in the
mm.
lab, this is hard because it's just a mannequin in a bed. But if I was
Yeah,
in the
indeed.
workplace, I would be much better able to do this, whatever it is, scenario.
Yeah,
So,
yeah. I understand that completely.
yeah. Well, thanks, Joel. That was a good wide-ranging chat.
Yeah, wasn't it?
And I hope it's useful to students just to
I
really
hope so.
consider approaches to people, how they can try to get some connection with people to really then be able to ask the question, how are you really
Yeah,
going? Yeah,
I guess if I was to conclude on anything, like really just talking to someone like they're a real person, is makes such a big difference, and not as um like a patient,
yep, yeah.
yeah.
And that's what my research said as well. The patients, well, they were recent inpatients. They said, we want to be seen as people first, and we've come in for help from you, but we want you to know us as people. And
Mm.
that's what we'd all want if we were in the situation of, reverse roles, wouldn't we?
Of course,
Yeah.
yeah.
Thanks, Joel. That
Thanks
was
so much,
really
Helen.
great.
You take care. Let me know what I can do for you.
Thank you.